that's what we're going to be talking about. It's a really good topic, and I can't wait. I can't wait to dive into it. I've got a lot to share, a lot of myself to share with you guys, and I hope it generates questions for you. And I'll absolutely, as always, do my very, very best to actually answer your questions. So I can't wait. Let me know when you're ready.
Okay. Hold on. Yes. Can you hear me? Hi.
Yeah, I can hear.
Yes, I'm sure you can hear me very well. All right. Good evening, people, everybody. It's me, myself, and I. We seem to have just had a technical blip where we've lost DJ Ish, but I'm here now. I'm stepping in. He doesn't have to introduce me today, because he does a rubbish job at it anyway. So I'm going to have to just introduce myself. Greetings and salutations, my people. It's your boy DJ Little, the Moses for Saloon ENT. As Ish said, we're here. I'm just the man behind the technical abilities when it comes to Dr. Achmed's show and others' shows. So I'm grateful. We're looking forward to tonight's show. And I can't just wait for Dr. Achmed to get on with proceedings. And we've got quite a lot of interest in terms of people that wants to join this program already, and we can see that. So Dr. Achmed, what I'll do, I'll just get you to feel the floor and just communicate to the audience out there. And if audience wants to engage with the program, we will be sharing the number out. But just in case, if you've got a pen and a piece of paper with you, the telephone number is 07951 213-881, 07951 If you are affected by this topic, or you have a loved one who's affected by this topic and is right up your street and you want to seek knowledge, tonight we're hoping that Dr. Achmed is going to share that knowledge, and you're going to learn. And don't worry, there's also opportunities to rewatch the program again on Facebook as well as YouTube, Diaspora Voices. Over to you, Dr. Achmed.
Yeah, no, thank you so much. So let's put a bit of framework around things. What we're going to talk about today is, all about all things sickle cell. So what it is, who's at risk of developing it, what are the symptoms of sickle cell disease, what and other associated conditions such as sickle cell trait. And how it's diagnosed. It's I see a lot of patients who it's usually the parents or couples who are thinking of having their first child, and they're wondering, do they want to have sickle cell or sickle cell trait, and what does it mean for them? So we'll talk about a little bit of genetic counseling and genetic risk. The risk of passing the gene on, the affected gene. We'll also look at what you can do if you've got sickle cell, what you can do as a parent to help your child who might have sickle cell. We'll look at some of the routine treatments, some of the more advanced treatments like bone marrow transplants, which is at present really the only cure for sickle cell disease. But in these parts of the world, where we find ourselves here in the UK and other developed countries, the treatment for sickle cell is so good nowadays, and people with sickle cell can have a pretty much near normal or normal life expectancy. We'll also talk about exercise in the context of sickle cell, and just like the Public Health England advises, everyone should do the 20 minutes of exercise a day, 150 minutes a week. That applies also to you if you've got sickle cell, but how you've got to do it in a certain way to reduce your risk of developing a sickle cell crisis, whilst exercising. So I'll be diving into all of those. But the first thing that I want to talk about is, what is sickle cell? I mean, I'm going to share, there are sections where I'm going to share some of my screen, and hope you don't mind. And what I want to just show you here, first of all, is this. So sickle cell is an inherited genetic condition of red blood cells. So red blood cells are the cells within our body, within our bloodstream that carries oxygen, takes oxygen away from the lungs, and takes that oxygen, which is very vital. We know how much oxygen is. In fact, I was watching something on success the other day, and it said, some people say they want to be successful, but if you really want to be successful, you're going to want success as bad as you want to breathe. So that's how vital oxygen is. That's just an analogy. Oxygen, without it, look, we can't survive. So it takes that oxygen away from the lungs all the way to all our organs, including our heart, to our brain, to our liver, kidneys, to our muscles, to our peripheries, our fingers, our toes. If that process is impaired in any way at all, then those tissues, those organs will be deprived of oxygen and will in fact die of something called hypoxic death. Like when someone has a heart attack, that's what happens. You cut off the circulation, but that happens quite suddenly through a different process. And the muscle, an area of the heart, no longer gets oxygenated blood and it dies and you get a heart attack. The same thing happens with stroke. Now, within the red blood cells, there is something called hemoglobin. Okay, so we've all got hemoglobin within us, and each hemoglobin has chains of alpha and beta heme, ion compounds. There are always two alpha, and in adults, most of the time, 97% of the time, there are two beta chains. Now, in sickle cell disease, the problem happens when there's a mutation, when there's a genetic abnormality, when the gene that codes for that beta chain is impaired in some way. And so you get sickle cell disease. Now, the most common type of genetic mutation gives us what we call the S sickle gene. If you have sickle cell, you probably would have heard of the term called HBSS. There are other types. There is the C type, there's the E type, but the S type is the most significant one in 70% of the cases, and it is the most severe form of genetic mutation. And for those that are interested, you get an amino acid called valine replacing glutamine along the gene. But look, that's not so important. I purely show this just because it will become relevant later on as we talk about how the genes are inherited. Now, I also mentioned you can have gamma or delta chain. So the gamma is what we have when we're in our mother's womb. So when we're in our mother's womb, we don't really have much of the beta hemoglobin. And this will come handy later when we talk about the newer forms of treatment, the sort of genetic forms of treatment to treat the disease by tampering with our underlying genetic makeup, genetic therapy. So we're born with our gamma, always with 2 alpha. We're born with our gamma, so we call it fetal hemoglobin, and that stays in us until about 6 months old. And then the beta hemoglobin, the adult form, takes over. Now, if someone has sickle cell, can just imagine if scientists somewhere can actually keep that fetal hemoglobin going for more than 6 months. So you switch it back on, so it comes back alive. And so that will actually cure someone with sickle cell of their sickle cell. So just hold on to that thought. But I just wanted to just mention that because that will come in handy later. So I'm going to unshare again, and we can just talk about sickle cell. So I mentioned it's an inherited condition of red blood cells, our red blood cells. So what does that mean, inherited? It means you only get sickle cell when your parent, you only get sickle cell when your parents give you the genes for sickle cell. So you inherit it from your parents, okay? Now, for sickle cell to happen, you have to inherit both sickle genes from each parent. So you're going to inherit one from your dad, one from your mom. If you only inherit one gene, one abnormal gene, then what you get is something called sickle cell trait. Okay, but if you inherit both, then you develop sickle cell, and that's because it is a recessive gene. So we have something called recessive and dominant But just remember that. Don't worry about recessive and dominant. Just remember, in order to get sickle cell, you need to inherit the gene. You need to inherit 2 copies of the abnormal genes, one from your mom, one from your dad. Okay? So that means they also need to have the abnormal gene. They may not have sickle cell disease themselves. They may only have the sickle cell trait. So they may only have one of the abnormal genes each. But if by probability they pass on those abnormal genes to you, then you will develop sickle cell. So what are the risk factors then of sickle cell? Well, look, we know that sickle cell is something that predominantly occurs in people of Black African and Black Caribbean origin, but it also happens in some people in the Middle East, in the Far East, in Asia also, but it's predominantly people of Black African, Black Caribbean origin. Now, globalization has happened. So sickle cell isn't just in Africa or in the Caribbean. It's everywhere, right? But it's usually people who are affiliated, who are originally from those sort of those groups, Black African, Black Caribbean. So that is really the risk factor. You see, in Africa, you can say, why is it only in Africa and not why wasn't it originally in Europe? You see, sickle cell trait, so when you only have 1 copy of the abnormal gene, actually gives you protection against malaria. Now we know what malaria does in Africa, how common it is. It is, we hear about lots of, people dying from lots of things. In fact, malaria kills more people than any other infectious disease in the world, and they're trying to get malaria vaccine, and if they can, that would be, that would be like a blessing. Whoever develops that, I'm sure will win the Nobel Prize for science. But I remember I used to get malaria quite bad, but I survived. And I always wondered when I started learning about this, I might have sickle cell traits, and I think indeed I do have a sickle cell trait. I don't carry the S gene, but I carry another form. I mentioned that there was C and E, and many people who made it out of Africa, alive, had malaria, didn't die from malaria, and probably also have sickle cell traits, or they may have just been lucky. If you don't have sickle cell and you get malaria, your chances of not surviving or dying from it are quite high. So that's why those groups. So it's in a sense, it's a survival advantage to have sickle cell traits in Africa, and those people who had it have migrated to other parts of the world. Now, when someone develops sickle cell, or if someone is at risk of developing sickle cell, it is important to know, what is my risk factor? Not of developing it, because you're born with the gene, so you've got what you've got already. So the concern always is, what are the chances of passing it on to my children? And that is what I want to just share with you now. I'm going to, just for this section, switch off my video because I want you to focus on the whiteboard here. Okay, I want you to focus on the whiteboard here. Yeah, DJ Little, can you see Can you see the whiteboard? Yeah.
Yes.
Okay. So, just for the purpose of this, we're going to say if someone has AA, so A is the adult normal hemoglobin. If someone has A, that's normal, okay? So if they have AA, so they've got 1 normal copy from their mom, 1 normal copy from their dad, that means they have normal hemoglobin, okay? If someone has SS, we're not going to talk about the other abnormal ones, but if someone has SS, that means they have sickle cell. They have sickle cell, okay? So AA is normal. AA is normal. And SS, sickle cell. Now, if someone has AS, so they have 1 normal gene from 1 parent, okay, and they have 1 abnormal gene from another parent, so they have AS. So this is what we call sickle cell trait. All right. I'm sorry for doing this because I know, no one expects to be in the classroom today, but I promise it's not going to be it's not going to be a classroom lecture, but it just helps, because if you've got this, a lot of the questions that people have is, but what are the chances of me passing it on to my children? Okay, so we're going to go through a few examples here. Now, if both parents are normal, so this is what happens in genetic, and this bit is really straightforward. If both parents are normal, okay, so that's parent 1, parent 2, okay, that's parent 1. Okay, let's make this easy. Let's not talk about parent. Let's say that's dad, okay, that's mom. Now, if mom and dad have normal hemoglobin, so what happens is when we pass our genes on to our children, we pass on the 1 copy each. 1 copy goes from mom, 1 copy goes to dad. So there are 4 ways that we can, give genes to our children. So this 1A here will go to will go in the sperm of the dad, in one of their sperm, and then this other A will go into one of the mom's egg, and they'll meet together. And this, if that egg and that sperm meet each other, then they will also have AA. So you can see, I mean, this is really easy. If both parents are normal, they don't, no one has sickle cell trait or sickle cell anemia, that is the SS, then all the children will just have normal genes as well. Yeah, so that's what will happen if both parents are normal. So all the children will have just normal genes like this. All right, so all parents, all the kids will be entirely normal. Yeah, so all kids, all children. Okay, now, if you have a scenario where the dad, let's say, well, it could be the dad or the mom, but let's just say the dad is normal like before, but now mom has a trait, okay? Mom has AS, so it could be the other way around, okay? I'm not picking on mom here, by the way, so don't get upset with me. It's just for ease of explanation. And say mom has AS, then what will happen here is you'll get this inheritance. You will get this, you'll have, so again, 1A will go from dad, 1 normal A will go from mom, the other normal A will go from dad, and that can also meet with the other normal A from mom. Now, here's what happens. Now you get the normal A meeting with the abnormal S from mom, okay? And then you also have the 4th option where the abnormal S from mom also meets with the abnormal A from dad. And so what you get in this scenario is you have, AA. So you have AA here for 2 of the potential offspring, 2 of the potential children. And then in this case here, you have AS. Right, so that will be trait. And that will be trait again. AS. Okay, now bear with us, because the thing is, when you just explain these things without drawing the diagrams, you can really lose people. I know we have a highly intelligent audience following us, but you can lose people. So if you have here, you have a scenario where one parent is normal, okay? One parent is normal, and the other parent has trait, and the other parent has trait, then what you get in that scenario is you have 50%. So you can see 2 out of the 4 potential options, 2 of those offspring will be normal. So there's a 50% chance of no sickle cell. Let's say normal, okay? Okay. Now, the other 50%, they have AS, so they're trait as well. So they also don't have sickle cell. And we'll put those in blue. So all our traits are in blue. So there's also 50% chance then that they will also have a trait chance. So the question, I'm going to just take my camera off for a second. So with those 2 examples there, you can see if both parents are normal, then all the children are likely to be normal as well. I say likely, but let's say almost 100%, because you can also get mutations or just random acts of nature problems that can just happen in when the embryo is developing. So there's always that theoretical possibility. But let's just, for the sake of simplicity, say 100%, all your kids will be normal. If one parent is normal, okay, and the other parent has sickle cell trait, there's a 50% chance that any child that you have will just be normal, and there's a 50% chance that the child will have trait. So there's a 0% chance that your child will have sickle cell disease. So you wouldn't have a child with sickle cell disease. So in terms of genetic counseling, if one parent has traits, then it will probably be important for the other parent to at least check whether they also have traits or whether they're normal. Because if they're normal, then for your children at least, you can say, well, we can have kids. We don't have to think about, well, what if our child develops sickle cell disease? But they may have traits, 50% chance, okay? So now I'm going to talk about the other scenario, which is, what happens when both parents have traits? What happens then? Now, you see, love doesn't look at your genetics. It doesn't look at our genetics. We fall in love with whoever we fall in love with. And this is for any, genetic condition out there. We fall in love and we may find out we have certain condition. And it's just important to know. So you're prepared mentally about what to expect, what to deal with in the future, what other options might be available to you in terms of being absolutely certain about the diagnosis, if that's what you choose to do. There are things that can be done. Okay, so this is if both parents have sickle cell trait. So I'm going to talk about that now here. So let me just switch my video off. Now, so both parents have trait. Okay, so one has A, and then one of their genes is A, the other gene is S. And here the other gene is S as well. Okay, great. So in this scenario, so I'm sure you're all experts at this now. So what happens? So you get one gene from dad going there. So let me just label this as traits. So these are both traits. Okay, silent, yeah, cheers. Okay, so both traits. So you get one gene from one parent going to that potential offspring, and then you get you also then get the normal gene from the other parent, and when that happens, then this child will be AA. So that will be normal. Okay. You could also have a scenario whereby you get one gene, one of the normal gene from the first parent, okay, combining with the abnormal gene from the second parent. And so this child will be AS, okay? AS, right? And then you have this scenario here, where again, now you got the abnormal gene from the first parent combining with the normal gene from the second parent. So, and this child will also have AS, okay? Will also have AS. So, okay, and then we have the final option whereby you can also get the abnormal gene from let's undo that. You can get the abnormal gene from the first parent combining with the abnormal gene from the second parent, and this child will have SS. Okay, so this child will have sickle cell disease. Okay, so if both parents have sickle cell traits, there is a 1 out of 4 chance. So look at the first option. There's a 1 out of 4 chance, which is 25%. So there's a 25% chance of normal, of the offspring being normal if both parents have traits. And then there is a 50% chance. So that's the 2 in the middle. 2 out of 4 is 50% that the child will have traits. And there's a 25% chance the child will have sickle cell disease. Okay. Now, I don't think I need to draw the fourth option, which is if both parents have sickle cell disease, just like with when both parents have normal, if both parents have sickle cell disease, so SS, then there's a 100% chance that your child would also have sickle cell disease. But I think the thing that throws up questions for couples is, I'm trait and you're trait. What are our chances of our children having sickle cell disease? So there is a 25% chance in that case of your child having sickle cell disease, 50% chance that the child will have traits, 25% that the child will not have sickle cell disease, so they'll have normal genetics. So another way of looking at it is there is a 3 out of 4 chance that my child will not have sickle cell disease at all, depending on how you want to look at it. Does it mean that your child will no, these are just probabilities, because the egg and the sperm meet in a very random way. So you could both have traits, and then all your children will be normal. They will, just by random acts of the egg, of the sperm fertilizing the egg, you get the A each time AA, and all your children will be normal. Or you could get by random action again, all your children having SS. So even though it's only 25% chance, but you could have 4, 5, however many children, and they all could also end up having sickle cell disease. So that is the end of my that is the end of my whiteboard lecture. Maybe I'll leave that on there for a second. I want to talk about, well, what happens actually in sickle cell disease in terms of signs and symptoms. But I'll leave that on there. I'll just save this in case anyone wants to come back to this later, actually. If I do that and minimize that, so we can always go back to that. Okay, so, let me pause there. Yeah.
Dr. Achmed, so in this case, who is more at risk and how can this be diagnosed?
It is a very good question. So so number one, as I mentioned earlier, sickle cell is a disease that predominantly affects people of Black, African, and Caribbean origin. So it's people like you and me who are more at risk as a general group. Okay, but if we know, if we know whether or not we have normal hemoglobin or we have sickle cell traits or sickle cell disease, then we can better risk stratify. So if you have normal hemoglobin, so AA, then your risk of passing it on is 0, okay? You don't have a sickle cell gene. If you have a sickle cell trait, then it depends whether your partner also has sickle cell traits. So as we've said here in the third option, if both partners have sickle cell traits, then there's a 25% chance that you can pass on, your child, your future child can have sickle cell disease. The people who are at highest risk are those, couples where both couples have sickle cell disease, and then there's a 100% chance that they can pass on, the gene for sickle cell to all their children. So they're most at risk. But I think that will be obvious to those couples, but it's usually the couples who are traits, perhaps, they're fine. So if you have sickle cell traits, you usually go through life without any of the symptoms of sickle cell, which I'll talk about. And so you've never had a reason to go to hospital to see a doctor for one of the symptoms of sickle cell, so you don't even know that you have it. So in fact, you could say, well, the people who have sickle cell traits but are unaware of it are probably more likely to pass it on because of the lack of awareness, because they could then fall in love with someone who also has traits. I'm not saying don't fall in love with someone who has traits, if you've got traits, but you can be quite conscious about the risk of passing it on to your children, and then have the right genetic counseling, and then you can have a test when within the first 3 months. Okay, they can take some cells from your amniotic fluid, amniocentesis they call it, and they can test that, and actually they can make a diagnosis of sickle cell, or whether that child has sickle cell or doesn't have sickle cell. And then as parents, you will know from a very early stage, by within the first 3 months, whether your child is going to have sickle cell, and you can prepare for what that might entail. You can have relevant counseling, etc., etc. They will guide you and support you, and ultimately, whatever decision you make, that's a decision for you as parents. So I don't know if that's that answers the question that you were asking. Was that what you meant, or?
Yes. And I've got another question. I just want to ask. I want you to throw light on this. What is the difference between sickle cell anemia and sickle cell disease?
It's a really, really good question, actually. I don't know where you got that from or who asked that. That's a really, it's a really, really good question. Now, so, earlier I mentioned that there are different types of hemoglobin, and that most of the time, we have, you have a problem with the beta gene, and that problem gives you the hemoglobin S, the sickle hemoglobin. Now, but you can also have a genetic abnormality with the beta gene that gives you hemoglobin C or hemoglobin E. They're milder versions of the sickle cell, right? And so sickle cell disease includes all of those. So inheritance of hemoglobin S or hemoglobin C or hemoglobin E, that's all sickle cell disease. But if a child with sickle cell has hemoglobin S from one parent and hemoglobin S from the other parent, that's called sickle cell anemia, because that is the most severe form of sickle cell disease. But you could have hemoglobin S from one parent and hemoglobin C from another parent. You still have sickle cell disease, but it's not as severe as having hemoglobin SS from both parents. So that's the difference. Sickle cell disease encompasses all of those, but sickle cell anemia is when you actually have hemoglobin S from one parent and hemoglobin S from the other parent. Yeah. So would it be useful to talk about maybe signs and symptoms? If someone has sickle cell disease, what they may actually experience, complain of, or if you're the parent of a child with sickle cell disease, it may actually be interesting to know, well, what symptoms should I be looking out for in my child? Should I go on and talk about that now? Would that be okay? Or is there another question?
Yeah, Dr. Achmed, before you, I've got another question, but before you go on that, we've got a sister who is here. She's here with us. I don't know whether she's got anything she wants to say. First and foremost, let me just welcome Nat B. Welcome, sister. I don't know whether you've got anything that you want to ask Dr. Achmed on the program tonight. Hello? Can you hear me?
Hang on. I was on mute, yeah.
Oh, okay.
I can hear you now, yeah.
Okay. Yeah, I said welcome to the program tonight. Thank you for joining. And I don't know if you've got any question that you want to ask Dr. Achmed.
Not at the moment, maybe later on.
All right, thank you.
I'm just listening to the presentation, which is really good.
Okay, thank you.
Very clear. I missed the beginning.
Okay, thank you. And we've got Sister Danke as well. Sister Danke, I don't know if you've got anything that you want to ask Dr. Achmed before we move on.
Yeah, hello.
Yes, Sister Danke.
Oh yeah, good evening.
Good evening.
Actually, I see lot of pancreas.
Yeah, that's fine.
I see this program and I'm so interested because I get picky when a 17-year-old where doctor say he gets sickle cell. I not agree to that because I'm not blessed, but I'm blessed. Those days, we used to go to the hospital like every week. They would say, oh, temperature, this, that. But for the past 8 years, no admission, no blood transmission. Yeah, okay. I think one time blood transmission, which was, I think 2000 and, well, 2008 years to now.
Sister Danke, you mind for come on the camera, please, if you don't mind?
Okay, wait till I wear something because I the rush.
Okay, well, go to talk while she sorts herself out. Go to talk.
Yes.
Go on.
So actually, they say he get so for the past 3 years, we're not going to hospital. Even because of that, all the benefits so then they give me picking and stop them. They do very well, normal, everything. Only the doctor would disturb me because first will be they admit. I said, Dr. Eunice now St. Thomas's Hospital. I said, oh, St. Thomas, I said, Dr. Eunice. I said, because one of my friends, she said, no, she's from Nigeria. They did bone marrow transplants to the son and he lived normal life now. He even live in America. So the doctor said, oh, your son is not in that situation. I can't do it. I said, no. I said, just refer me. I said, if you refer me, I think it was St. Mary. He said, no, he can't refer me. Even because of that, I was rude with him because he did a lot of things which he didn't make me happy. Even sometimes I will have an appointment with my son. I will stay in the hospital, St. Thomas's, and the clinic will close. He did it like 3 times. And they will just come and meet me. Oh, do you have an appointment? I said, yes. I said, I've been here more than 3 hours.
Hello, Sister Tiggy.
Yeah.
Hi, this is the producer, DJ Litson.
Yeah.
Hi, how are you? Well done. Great program. I'm really enjoying your story that you're telling Dr. Achmed to support. But if I can just give you a quick advice, I'll break into Creole now. So we English listen. Not call the name of the hospital, them, not call doctor name them, please. Before you
Okay.
Yeah, I beg.
Okay.
So just explain the story, not mention the hospital name, not mention the doctor name. Yeah.
Okay, that's fine.
Okay, go ahead.
So I do a lot of stuff, but I still get the courage, which me picking they live normal life. I know say me picking not get sickle cell. That's I believe on now my prayers, because they even put him to oxygen, which they said, oh, he has to take us oxygen 24 hours. And I've been traveling with him even to Sierra Leone 5 times. He lived normal life. They said SS from 2004 to now. So I wanted to do the bone marrow transplant, which he refused. He said he was not going to refer me. So I'm happy when they said now all those stuff going to be available in NHS, because I still want to do it just to prove, but I know my son is feeling well.
Okay.
Yes.
That is, thank you so much.
So, Sister
Let me come
Tindake,
in.
which you get question you want to ask Dr. Achmed, or you get any support you want to let Dr. Achmed support you with on this right now?
Yeah, the bone marrow transplant, I will love it for my son.
Okay.
Okay. Thank you so much for. I think, look, it's always really brave, to come on shows like this and share your story, your personal story with the whole world. It really helps to open up opportunities for others, and we always welcome it. Thank you so much. I mean, I'm going to talk about treatments, including bone marrow transplant, in a little bit. But I'll say to you, my simple answer to you will be: if your son is so well that he doesn't need blood transfusion, isn't on any treatment, isn't getting any complications, not going into hospital for oxygen, then your son doesn't need bone marrow transplants. And in fact, he doesn't meet the criteria for bone marrow transplant as it is at the moment. Because I will tell you a little bit about bone marrow transplant in a second. And if you have to go and miss that, you can always watch this as well later on. But I want to come to that because you've mentioned a lot of the things that causes symptoms in sickle cell. So that is what I really want to just talk to you about now, if that's okay. And that is this, right? So if I just share with you, you see in sickle cell you have, because of this abnormal hemoglobin, because of the abnormal hemoglobin, it changes the structure of the red blood cell, and that's precisely why it's called sickle. That's why it's called sickle cell. It changes the structure of the red blood cells. Your normal red blood cell is nice and round, yeah. Your normal red blood cell is nice and round, and it can go through the blood vessels without any problem at all. In fact, it's not quite round. It's a nice sort of disc shape. Now, if you've got sickle cell, you've got this abnormal hemoglobin. What happens is when the red blood cells are in an area where the oxygen level is low, or low oxygen tension, we call it, or it's really, really cold in the peripheries, in your fingers, your toes. So the red cells, they become stressed, and it changes the shape of the red blood cells into a sickle shape. And that's why they get that, they have that name, sickle cell. You see, so this is it. So your normal red blood cell will look something like this, nice and round. Excuse me. Okay. Now, if you've got sickle cell, then what happens is they look like this. Okay, just like a sickle, like a crescent shape. Okay. So normal, okay, sickle. So you can see, just even looking at that shape there, when that cell goes into that shape and it's flowing in a smaller blood vessel, it gets stuck. It can't flow properly. It gets stuck, and they all bunch over each other. And as a result of that, it actually then stops blood getting to the organs that I mentioned earlier: your heart, your brain, your kidneys, etc., your toes. You stop the flow of oxygen getting to those organs. Okay, and as a result, you get death of those organs if that person doesn't then go into hospital and get oxygen, or doesn't go into hospital, or they don't rehydrate themselves. But there are things that you can do as well. They don't rehydrate themselves, or maybe it may have happened because of an infection. If the infection doesn't get treated, then it causes a lot of problems. So a lot of the problems that happen in sickle cell is because you're getting these sickle cells, sickle-shaped cells, blocking up the smaller blood vessels. So the obvious one, as I mentioned, if you get blockage of a blood vessel, then you get no blood flowing to that tissue. Therefore, you get no oxygen. Okay. You also can then. So what can happen if blood or oxygen doesn't flow to the tissue? You get death of that tissue, as I mentioned. So from a very young age, from about 6 months upwards, once the child's fetal hemoglobin has gone out of their system and they only have the sickle cells, you can actually be at risk of developing stroke. Yeah, so small children, little children, can develop stroke from sickle cell. And what they do in hospital is, if a child has sickle cell when they're very young, they do an ultrasound scan of their brain, transcranial ultrasound scan, periodically to check whether they're at risk of having a stroke. If you also, if that happens to your heart, then you could have a heart attack. So someone with sickle cell could potentially have a heart attack at a very young age. And there is something called a chest crisis, where you get a blockage of blood flow to an area of the lungs. Now, look, the oxygen comes from a normal working lung. So if the lung itself gets affected, not only is the lung being damaged, but it also means you cannot even get sufficient oxygen into that lung. So that is one of the most serious complications that anyone with sickle cell can develop. We call it a chest crisis. Often they get severe chest pain, they're very breathless, they have to go into hospital, be given oxygen. Sometimes even they need to go to intensive care and be supported with high flow oxygen, or if necessary, life support machine intubation. So that's one of the complications. The other complications, some of the things we probably see back in Africa, are, ulcers. Yeah? So leg wounds, big, terrible wounds that don't get well at all. Okay, in young people, that can be because of sickle cell, because they're not getting blood, sufficient blood flowing to that wound, and without oxygen, again, the wound is pretty much not going to heal, no matter what you do, no matter what dressing, what treatment you give that wound. It's not going to heal. Now, pain is very common as well. It's in fact one of the most common symptoms that patients with sickle cell have, and often it's pain in the bones, in the joints. And it's not as severe as the stroke or the sickle crisis, but it can be very, very problematic for patients. And again, if you are someone with sickle cell, or you're a parent of someone with sickle cell, it's really important to tell your child, or for you to keep yourself well hydrated, to avoid extremes of temperature. So either very, very hot temperature, which is why infection sometimes, infections are a problem, or very, very cold temperature. And that can cause pain. And, the hydration helps. Sometimes you might need painkillers like paracetamol, sometimes ibuprofen, but you've got to be careful with taking too much ibuprofen, because that can affect your kidneys. Sometimes you actually need really, really strong painkillers, and which you can only get in hospital. So things like morphine, as strong as morphine, you might need to control your pain. So the other complication you can have, and this applies only to men. So
Dr. Achmed, sorry, I think we've got a caller. I think we've got a caller that wants to ask you a question.
Yes. Yeah. Okay. Let's go. Let's go for it. They're on the line now. You're on mute, DJ Little.
Sorry, caller.
Hi, good evening.
Yeah, go ahead.
Hi, good evening. Can you hear me?
Yeah, good evening. We can hear you. Yeah.
Okay, my name is Kadi. I have HBSS, and I actually have a charity that I run in Sierra Leone, and I support kids with sickle cell. So we've got two people, two of them who've got leg ulcers. And at the minute, we're doing a inside study for leg ulcer, sickle cell and leg ulcer. Okay, I just wanted to find out, how often do you think they should have dressing on those ulcers? Because we did one last week. Was it last week? Last week of September, we did screening on the 30th of September. But I was wondering, how often would they need the wounds dressing? That was one. And my other question was, I am contemplating on taking vaccine, but I don't know which one to take, because we know one of them, develop, you get blood clots with them, and it would be ideal for somebody with sickle. So it's a bit of a dilemma for me, so those are my two questions.
Thank you so much. I think those are really, really good questions, and congratulations, and thank you so much for what you're doing with the kids with leg ulcers back in Sierra Leone. In terms of how often to address the leg ulcers, I think it depends on the ulcer itself, how it looks. So that will be determined by the nurses, the clinicians there at the time. But in terms of, well, I guess what you're asking is, because of the sickle cell, what else can be done to actually help the healing of the ulcers? So as I mentioned earlier, it's all to do with the blockage of the circulation of the flow of blood to the skin, to the tissues in that area that makes the healing of ulcers extremely difficult. So it's dealing with the anemia, not just the ulcer, because the ulcer is a symptom, but it's dealing with the anemia. Now, what can be done in Sierra Leone, the part of Sierra Leone that you're at, in terms of making sure that the hemoglobin is topped up as much as possible. If it was in this country, they'll be getting fairly regular blood transfusion to make sure that they have not just a lot of sickle hemoglobin in there, but they have some normal hemoglobin. But that's the purpose of doing the transfusion. Because what happens, you probably know this, what happens is the normal hemoglobin that you can see on the screen will last in your body for about 90 to 120 days. Okay, so 3 to 4 months it will last. Whereas the sickle hemoglobin only has a lifespan of about 10 to 20 days. Right? Only about 10 to 20 days. So it lasts so much shorter. It can't last very long. So it gets broken down and it hemolyzes, we call it, quite a lot. So as a result, people with sickle cell have really, really low levels of hemoglobin. But if you transfuse them regularly, so you're giving them blood from someone else who has normal hemoglobin, then they can have normal hemoglobin for 90 to 120 days at least, enabling them to get oxygen to those tissues, and then the ulcer is more likely to heal them. So that is probably the most important thing. Of course, here there are other additional drugs which I'll come on to later, things like hydroxyurea that they give patients. We know that if you take hydroxyurea, not hydroxychloroquine that people were hearing about with COVID, this is hydroxyurea. Now, if you take hydroxyurea, it actually significantly reduces your requirement for blood transfusion. So that's what I would say, Kadi. It's working with the clinicians there on what can be done to improve their hemoglobin and making sure they're well hydrated in that heat of Sierra Leone, so they don't get a lot of disturbance to the flow of blood to those tissues. And in terms of the ulcer itself, it depends on how it looks, because you can have an ulcer that's not infected. It's just an ulcer is just a breach of the top layer of the skin. Now it can just be there, and it will just be there forever and ever if it's not getting enough oxygen going to it. Or you can have an ulcer that looks dirty, that looks infected. That ulcer that looks infected needs more regular treatment. Because without that, the wound can get deeper and deeper, and the infection can get into the bone and cause something called osteomyelitis, which can be a terrible thing for anyone to have, let alone someone with sickle cell. So I hope that helps there.
Yeah, Dr. Achmed, after answering Kadi's second question about the vaccine, you've got another caller on the line.
Okay, yes. So your other question about the vaccine, let me show you this. I don't know if this is a really, really important, support organization. You can see my screen. It's the Sickle Cell Society. All right. So Kadi, if you haven't come across this organization, definitely, go and look them up. They have a lot of information about COVID vaccine and sickle cell. You can see it here, coronavirus. They've actually written a document on COVID, coronavirus, and sickle cell, which you can open up. They're called a Sickle Cell Society, and it gives you a lot of information, because just like you, a lot of people with sickle cell are anxious about whether they should take the COVID vaccine. Their support is emphatic that you should take the COVID vaccine. the Pfizer vaccine that's been given out, because actually, if you get sick, if you get COVID and you have sickle cell, you're not likely to do as well. Let's put it that way. You're not likely to do as well as someone who doesn't have sickle cell. But have a look at that. They have a lot of useful information just to support you. It goes through all the sort of anxieties that you may have, that lots of patients with sickle cell have. So Sickle Cell Society, hope that's helpful.
Thank you,
okay.
Thank you, Dr. Achmed. DJ Little, you can put the next caller on, please.
Caller is on. Caller, please speak.
Hello?
Yeah, caller, speak, please.
Hello?
Caller, please.
Yeah, we can hear you.
Well, you have to turn down your other device, caller. We can hear you.
Hello?
Yeah, caller, you're live on air. Please speak. Turn down your volume.
Good evening.
Good evening.
Okay, we're having a delay. Caller, turn down your other device because there's a delay, and have a normal conversation. Don't listen to your device, caller. Hello, caller, you're live on air. Please speak.
Wab, is that me? Is that Bridget?
That's correct. Please speak.
Okay. Good evening. My name is Bridget.
Good evening, Bridget. Welcome to Diaspora Voices.
Yeah. My son has got sickle cell and he's 9.
Yeah, carry on, please.
Yeah. Okay. The first thing I want to say is a pledge, because I asked somebody earlier on saying that the child doesn't have sickle cell. Right. Let's don't make those statements. If it's been diagnosed, it's got sickle cell. Right. So let's seek the treatment that is there for us. Right. My son is on blood transfusion.
Yeah, well, I'll keep talking and we can hear you, caller.
Yeah, sure. Yeah. So at the end of the day, if we stick the treatment that is available to them, it will be better for them. They will have a better life, right? It's like the doctor was going to say something. People suffer from different forms of crisis, right? My son suffered from something called priapism. At a very young age, it will have erection of his penis, and that is very painful. You know, some people will not have the daily crisis of the leg, the knee, the ankles, you understand? But there are other things, and he talks about the brain scan. So with that brain scan, they know that a child with sickle cell up to the age of 16, they have a high risk of stroke. So at the end of the day, Mark's son has been doing that, and they found out that he's got that. So his blood flow on his the left side is very high. So because of that, now he's on blood transfusion. But for me, I accepted that because my ex-partner is sickle cell and I'm AS. So, but what I'm saying, I was like, when you go for medical advice, take it, don't start, oh, because of this and that. No. Because they suffer in different forms. So let's listen to the experts and take the advice on board, because you don't suffer, that child suffers, you know. So for me, it's just a pledge that I'll be making, because I go through it every day and I take the medical advice. So if your child has got sickle cell, don't make that claim that, oh, he's well, he's fine, you know, I'm blessed. We are all blessed. But if he's got sickle cell, it's genetics, right? It's not about blessing, it's there. Let's seek the medical advice and treatment that is there for our children. Or even
thank you so much.
Thank you, Bridget. Dr. Achmed, I'll let you respond to that. I think you've got another caller on the line as well.
Yeah, no, thank you, Bridget. I mean, I think, you know, as I'm going through all these various symptoms that people can have, with sickle cell can have, as Bridget just rightly said, you know, different people will experience different symptoms. So someone with HBSS, in fact, you could both have HBSS, the most severe form, but you still experience different symptoms. But someone with HBSS, the most severe form, compared to someone that's HBSC or SE, they will not experience the same symptoms. So yeah, I think thank you so much for your points. And what before I come on to the next caller, you know, she mentioned that her son has priapism, and I was just about to touch on that point when I said this is a symptom specific to men or boys who have sickle cell, and she's explained it. And priapism, some of you who follow this show would have heard us talk about it, you know, when we talked about erectile dysfunction, and one of the complications of Viagra is priapism. So priapism is a prolonged, painful erection, okay? Prolonged, painful erection that becomes a medical emergency when that erection is going on for more than 4 hours, all right? It actually can cause death of the penis. So it's like you have stroke of the brain, it can cause stroke of the penis. It's a very devastating symptom. So I mean, you know, thanks for sharing your story. Imagine a child experiencing that. It has, you know, so many different implications for that child. Now, look, when we talked about erectile dysfunction, we said if you get priapism, you can go to the bathroom, get some cold shower, cold water. Remember, you don't do the same here because sickle cell doesn't. Your sickle red blood cells do not like extremes of temperature. So don't go and run cold water on it. It would actually make the cells sickle more. Because what's happening in priapism is the cells get sickled, they block up the flow of blood outwards, away from the penis. And so you have blood going in, but it can't leave. So you have this prolonged painful. And if you go and run a cold shower on this, it actually makes it worse. So what you want to do is get hydrated, painkillers, and actually, you know, seek medical advice early, you know, going to hospital. For people who have it lots and lots, of course, there's a blood transfusion, hydroxyurea, but there are also specific medication hematologist can give you. So very, very painful. Before I come on to the next caller, let's just say something about how it can affect women specifically. And this is really in relation to pregnancy. If you have sickle cell and you get pregnant, you have a higher risk of miscarriage, a higher risk of low birth weight. So the child being much smaller than what you'd expect them to be for their age. You also have a higher risk of hypertension of pregnancy, so we call it pre-eclampsia. You have a higher risk of blood clots in pregnancy. So pregnant women, by default, have a higher risk of blood clots, okay, compared to the average population, women in the population. But if
Dr. Achmed, I want to hold you there. Let me just welcome Molly.
Yes, let's go.
And I'll allow DJ Little to read some comments that I want you to just buttress on. Over to you, DJ Little.
Yeah, sorry, Dr. Achmed, we do apologize for the constant interruption.
Yeah,
it's as a result.
No, come on. This is about the people. So bring the comments and the questions.
Yeah, it's as a result of the success of the program so far. So if I am to read the question. So this is coming from Marie Rosetta Facundo. It says, Doc, I have questions. What is that sickle cell illness is more found in West African countries? Next question. So question one, why is that sickle cell is more found in West African countries? Second question is, why is only Black people illness, but I understand that the Jewish people have a similar illness of blood condition that has almost same blood effects, etc. Could you enlighten us on that? Or there may be genetically evidence between Jewish and Black Africans. Marie carried on to say, as they are the only white human beings that has similar blood illness like us. Thank you. Plenty of loves and hearts.
Thank you so much for your question. So I know you probably missed the beginning because we talked about, you know, why it's a condition that's more common in Black African, Black Caribbeans. It gives us a survival advantage against malaria, in particular sickle cell traits. And so we've carried that gene. You know, it's that's how you know, inheritance works. So species that have a survival advantage will outlast those that don't. So in Africa, there's a lot of malaria. And so if you have sickle cell traits, that actually protects you against getting devastating malaria. So what happened is, back then, all of those people with normal hemoglobin, they died from malaria because they just couldn't survive it at all. And those with sickle cell traits survived. And so the gene has been propagated. And then we've all moved to different parts of the world carrying the sickle cell trait gene, and we're passing it on from generation to generation. In terms of the Jewish now, there are so many blood conditions that are particularly common in the Jewish population, so I can't comment on that. If you were referring to thalassemia, that will probably be for another show, but yes, they do. There is, again, that is another genetic condition. But sickle cell, look, it's more common in Black African Caribbeans, but we also see it in some people in the Middle East, some people in Asia, in the Far East as well. And of course, there's a lot of intermarrying now, so you can, you know, you can see it in other ethnicities also. I hope that I hope that answers the question. But thank you for asking.
Right, thank you very much, Dr. Achmed. Yeah, you can carry on. I hope I will not interrupt you again.
No, please interrupt. You know what I'm like. Once I start talking, it's it's difficult to stop at times. So just stop me as we go along. You see, you know, one of the things that I wanted to now actually move on is the treatment. I mean, the good thing about getting the questions is we've actually been addressing some of this as we've been going along. Okay, so if a child or someone has sickle cell, it's very important. So I always like to start with, what can you do for yourself, right? Before what the clinicians can do for you. So, you know, number one, this is any condition you have, try and get yourself educated about it as much as possible. So you're not just going to a doctor and then having a one-way conversation. Okay, do this, do that, do this, do that. And you know, you don't understand why you're doing this. So get really educated. Lots of, I mean, we're blessed now with the internet, right? You know, there's so many groups that you can join on Facebook. You have that Sickle Cell Society here in the UK. They're very active. There are lots of others as well you can join. So get educated, know what you're talking about, and have a high-level conversation with your clinician. So keeping well hydrated is important. So making sure you're drinking plenty of fluids throughout the day, avoiding cold, hot, extremely cold, extremely hot temperatures. The cold in particular, especially in the winter months, will cause crisis. Now, when you have sickle cell, again, everything that we get in sickle cell is because of blockage of the blood flow to various organs. In the spleen in particular, the spleen, so it's a big organ, just like your liver, but your liver is on your right side, your spleen is on your left side. The spleen is everything to do with your, you know, cleaning up your blood, you know, sort of getting rid of old, withered red blood cells. Now, if you get a crisis in the spleen, there's a crisis called splenic sequestration, where you get loads of your blood cells, they just get stuck in the spleen, and that can rapidly increase the size of the spleen. So this is where someone with sickle cell, often a child, their stomach gets massively enlarged. All of a sudden, it can happen in front of a parent's eye. And so if, is that a point? Yeah. So, you know, you can get a massive spleen, and as a parent, this is why I'm saying get educated. You can save your child's life, because if you look at your child's tummy, your child is complaining of, you know, abdominal pain, or you know, my tummy hurts, they've got sickle cell. You want to know how to fill the spleen. So you don't have to be a doctor to be able to do that. They can teach you how to do that. You want to detect that early, seek medical advice. It is a medical emergency. Okay, you can save your child's life. So splenic sequestration is a very important complication. It can happen in the liver, but when it happens in the spleen in particular, it can be terrible. Now, because is that someone wants to ask questions or?
Yeah.
Yeah. Okay.
Yes.
I'll pause. I'll take a pause.
Shall we go over to Nat B first, please?
Yeah, Nat B. Yeah, over to you, Nat B.
It was earlier on about the advantage of having a sickle trait with regard to malaria. Is there a science behind that?
Oh yeah, there's a lot of studies in the literature about it. That if you've got sickle cell trait, malaria doesn't affect you as severely. You can still get malaria, but it doesn't affect you as severely as if you've got normal, completely normal blood cells. And you're even more protected if you have sickle cell disease. But of course, sickle cell disease has its own negative connotation. So if you go into Google, whenever, this is an advice for anyone, whenever you want to search something scientific in Google, for those who don't know, if you type whatever it is you want to search and you type scholar, SCHOLAR at the end, so you can type sickle cell trait plus malaria plus scholar, so you get all the scholarly articles on that.
Okay. Thank you.
Let's move on to share class now. Thank you, Nat B. We'll move on to share class. Share class, if you could unmute, please.
Thank you. Excellent session as always. When healthcare, I just wanted to go to the very beginning, which is about how do we actually educate our youngsters to not actually get into this situation in the first. What I mean is to not get, because it's genetically preventable. So how much education are we actually putting out there to educate our youngsters before they go to university, gather them together and explain how sickle cell trait is inherited in the first place? Thank you.
Excellent question.
Thank you very much.
Thank you so much. I think that's a really good question. And I say kudos to people like the Diaspora Voices for putting on shows like this. This is part of the education, and it's all our responsibility when we see shows like this to share it and circulate it with as many people in our communities and children, get them to watch. But I think it starts with the parent, because if a child has sickle cell, the parent's been dealing with that from a very young age, and you hope, this is why I'm saying get educated. So even as a parent, don't just have a one-way conversation with your clinician. It starts with you, the individual. So get educated as much as possible, educate your child as much as possible, engage them in programs like this, engage them in organizations like the Sickle Cell Society, support groups as much as possible. If your child, and also it starts with, let's take it back, let's even take it way back. I think I don't know if that's your real name, Share Class. So when your child is young and they start nursery, they go to primary school, through school, you don't want to leave things to chances. The nursery nurse is probably not going to know that if your child complains of tummy pain or they start crying, because they might be too young to even say, I have pain in my arm or my leg, that in that particular child, they must take it super seriously. So you've got to get them educated and tell them. And if it's helpful, speak to your GP, your specialist nurse, your hematologist, so you can get a treatment program in place for that nursery or for that primary school. They've all got to be super educated. As your child then gets older, you educate the child also about their condition, making sure that if they're going to, going on trips, going to play with friends, it's important to make sure they're well hydrated. Now, I was going to touch on the fact that when the spleen gets damaged over time, so it doesn't have to be the splenic sequestration that I mentioned earlier, but over time you can get little, like mini strokes of the spleen. So eventually what happens is your spleen, you have a spleen, but it's actually not functioning well, okay? When that happens, you become at significantly high risk of developing bacterial infections. So we say it's all encapsulated bacteria. So you're at risk of getting severe pneumonia, severe tonsillitis, severe meningitis, lots and lots of different types of bacterial infections. As a result, we normally put patients with sickle cell on regular antibiotics. We've got prophylactic antibiotics. So this is antibiotic that you take on a daily basis, whether or not you have an infection. So prevent the risk of you getting an infection. And if you get an infection, you start treating it early. So, and this education, so I mentioned it starts at the home, then the kids, it comes even to us, the clinicians, right? It comes to us, the clinicians, because I'll tell you, not every, just like you have, you have various professions, some people will be more adept at dealing with certain conditions, right? You'll have GPs who know more about sickle cell, and you have GPs who haven't been exposed as much to sickle cell. So we also need to, educate ourselves. And when you work in this part of the world, you don't see sickle cell as much as a doctor in Africa. But even in this part of the world, when you work in somewhere like Southeast London or in London in general, where there are more ethnic minorities, you will come across sickle cell more. Now, if you had sickle cell and you were living outside of London, your GP may not, because of their background, their exposure, their experience, they might not necessarily be so hot, let me use that term, so hot on the management of sickle cell. I mean, we learn, GPs, they're incredible human beings. We learn so much, we learn so widely. But if you're not seeing something on a daily basis, then, you might not be so. So this is why you need to make sure that you're as well educated on the condition as possible.
Dr. Achmed,
was there another question there?
Yeah, Natsby has got a question that she wants to ask. Yeah, Natsby, on mute, please.
No, it was just I wanted to put my hand down. I think I've touched the wrong.
Oh, okay.
It should be down.
Okay.
Thank you.
No problem.
That's fine. You've put it up again, so put it down again.
Oh, hang on. Let me put it back down.
Well, Dr. Achmed, the question I want to ask here is, someone with sickle cell, how risky can they be if they catch COVID-19?
Yeah, it's a good question. Look, we don't want to be scaremongering, right? But if you've got sickle cell, you have been in a high risk group, in the shielding group of patients. And that's because any infection that you get if you've got sickle cell can be detrimental, because it increases the risk of a crisis developing, and it means you're more likely to develop complications, not just mild complications, but serious complications like chest complications, chest crisis that I mentioned earlier. I mean, with COVID, for example, you get a lot of patients who develop a pneumonia, right? You get a lot of patients who even develop blood clots. If the problem with sickle cell is getting oxygen to your organs because you're blocking the flow of oxygen, if that is the problem, and then the actual organ that gives you the oxygen gets damaged by a pneumonia or blood clots, it can be quite catastrophic for that patient. So it's really, really important that we do our best. If you've got sickle cell, to get the COVID vaccine. The Sickle Cell Society, they're not just a society by themselves, they work with a lot of the top hematologists in the UK. They advocate for that as well, have the COVID vaccine. Read their guideline. I know people have a lot of queries, concerns about it, but it's super important that you don't get COVID in the first place. So, take all the necessary precautions as well. All the basic things that they're going about, washing hands, mask, space. And I think even though we're opening up, you got to still be more careful and not just be blasé about the whole thing. And I'm not saying anyone is, but, we're social beings. When we see other people walking around, going into supermarkets, going into restaurants, not wearing face masks, even if you want to do it because you know that it's important that I protect myself, you feel inhibited. You're like, well, I'm gonna be the only one who's wearing face mask here. I don't feel right. and so I just won't wear it. So be brave, okay? Be brave. Wear it, protect yourself if you feel you're at significant risk. Yeah.
But thank you.
Any other questions?
DJ Little, I don't know whether you've got a question for Dr. Achmed before he actually moved to his second segment of the show.
Okay. Let me just come onto the screen, and it's going well. I just want to go through a few comments,
Yes.
Dr. Achmed. I'm just going to try and come onto the screen. And so what it is, Dr. Achmed, I'm going to read, first of all, some of the comments that have been coming in because it's really engaging. And there's been so much interactions on the Facebook, and it's going well. One of the comments that has come through has come from one of our sisters, and also somebody that's very known and respected within the community. Sorry, bear with me. I apologize. So I was just trying to get my screen on because the number was doubling up for. Yeah. So can you see me now?
Yes.
All right. Thank you very much, DJ Ish. Right. So the comments has come from Saleh Peggy Joe. Saleh Peggy Joe says, very educative. As I work in hematology, dealing with blood-related illnesses. And Isata Rogers says, thanks for educating us. KD says, thanks a million. Koki Moba says, Doctor, please don't forget to answer the first question. And I've been engaging with Koki. Koki says, it's not a question from herself. It said that's from the question referring to the lady who was making reference to the hospital names and the doctor's names. So I don't know if you can recall that question, the conversation that ensued. Marie Rosetta, I think, added, says, is it because the person with the illness has more white blood cells and less red blood cells, probably may not be edible for the mosquitoes? That's okay. With a good sense of humor, I guess you know what the rest was going to come by, but I think that's a very interesting take on it from Marie. That's a very good way to look at it. Okay, we've got Bashiru Barry watching, Ramatu Kamara watching, and many other. Also, we've got Auntie Betty Fala has joined us live on the Zoom. As we know, one of our leading healthcare professionals and former chair lady and founder of Toshpa. So yes, Dr. Achmed, those are the comments so far. The question I was going to ask you is,
DJ Little, can I give honor to Elizabeth quickly, and then before you ask Dr. Achmed, please?
Go ahead.
Yeah, Elizabeth, go ahead and ask your question, please.
Oh.
That's my Auntie Betty Fala you're calling Elizabeth. Hey, if I owe you. That's my mother.
I'm sorry, Auntie Elizabeth.
Oh, just 1 minute. Sorry. Oh, sorry, I'm on mute.
No, Auntie Betty, you're live on air.
You're live.
Yes. Okay. Dr. Achmed.
Hello, Auntie Betty.
Yeah, how are you? Long time.
I know. Good to see you.
My question is from my own public health background, because I used to do a lot of school health back in Africa, and we used to do a lot of teaching. Does the school nurses carry out health promotion or education about sickle cell in schools?
You mean here in the UK?
Yeah, here in UK, yeah. Because they are attached to GP surgeries or primary healthcare, right? Do you know whether they carry out any health education about diseases like or conditions like sickle cell disease in schools? Because when I just joined, you were talking about health education of parents, etc. So do they do that? Yeah.
The short answer is most likely no. You'd find, I think, because sickle cell, yeah, because it's not something that's, you know, so prevalent in these parts of the country, in these parts of the world. You find school nurses generally don't, you know, they don't do any of those health campaigns. They probably, this is not to be offensive to any school nurse, they probably are just not well educated on that area. Those who will be better placed are the actual hematology nurses. And whether or not they carry health education in schools, I'm not sure actually. But that would certainly be something really, really good for them to do, especially in schools in Southeast London, you know, in or in London in general. So yeah, that would be a really, really good thing. I'm not entirely sure, but I can find out from the hematologist, the hematology team at King's College to see whether they do anything like that.
Yeah, because I think we always say in public health, catch them early. That means educate them at an early stage.
That's right.
Yes, so I'm not saying even primary school, they should know about certain things, but more of those in secondary schools, because that's the time they start dating. So then they need to be educated, really. Yeah, I think, yeah, if you pick that up with King's College, the hematology department at King's College, because I think, of course, the public health we did back home, it was based on primary healthcare, where we take education to the grassroots for people to, you know, to know about health conditions. But I did public health here again in England, Green University, but it's quite, the approach is quite different from what I did in Nigeria and practiced it in Sierra Leone. Yeah, so that would be nice. I think they need to catch them early. The education needs to start early. Thank you.
Thank you very much.
Thank you so much.
You're welcome.
DJ, it's over to you.
That's fine. I'll just let Dr. Achmed to proceed.
Brilliant. So look, you know, we talked about a lot of the treatments. I mentioned the antibiotic. One of the parents mentioned that their child gets regular blood transfusion. That's really important because the red blood cell in someone with sickle cell lasts 10 to 20 days, whereas in someone without sickle cell lasts 90 to 120 days. The red blood cell in someone with sickle cell breaks down a lot easily. And when you have a lot of red blood cells breaking down, it can cause jaundice as well. So jaundice isn't just because of primary liver problem. You have bilirubin in the red blood cell. It's a breakdown product of red blood cells. And what is jaundice? You probably all know jaundice is where your eyes or your skin, it might be difficult in a black person to see the skin going yellow, but if you look at the palms of their hands, that can go yellow. And if you look at the whites of the sclera, that can go yellow as well. There are other more advanced treatment. I mentioned that hydroxyurea earlier, and there are new, at the moment, there's a lot of research being done in sickle cell. Now as you can understand, you know, in the pre-70s, 1970s, even 1980s, there wasn't much research being done in a disease that predominantly affects Black people, right? In Western Europe. Now, we don't have the infrastructure to do the advanced research that's necessary to further the improvement and advancement in the knowledge of sickle cell in Africa. But through the 80s, 90s, so much research has been done to the point where, you know, in the late 90s to early 2000s, life expectancy from sickle cell in the West, in developed countries, significantly improved from late teens, 20s to 40s, 50s, and now people are having normal life expectancy. The only cure, there are lots of biological agents. So these are things that sort of try to modulate the immune system. In fact, if I show you something here, there is something I saved earlier to just show you briefly. If you're watching, you can, and this only came up on the BBC the other day. Yeah, 6 days ago. The first new treatment for sickle cell in 20 years. All right, 20 years. So, you know, this is a condition that affects, you know, so many of us. In the UK, 300 cases of sickle cell confirmed in newborns every single year. you might think, well, that's small, but if you look at, well, a lot of these cases are within the Black population. So maybe don't look at 300 out of the whole of the UK, look at 300 out of the whole of the Black population, ethnic minority population in the UK. So this is one of the new biological drugs that's coming out at the moment. The only cure, and we need to touch on this, the only cure for sickle cell is bone marrow transplant. Now, what is bone marrow transplant? Bone marrow, so your bone marrow, we've all, many of us here, I'm sure, have chewed bone before. It's
Dr. Achmed, I have to hold you there again. There is another caller as well on the line.
Okay, no problem, no problem.
DJ Little, you can put her on the line.
Go ahead.
Hello, yeah, this was in relation to Auntie Elizabeth's question. I don't know if it will help, but what normally happens is, like, for my son, because he's the only one in the school, so
we've lost the caller.
the community nurse, and they come have a talk in the school. You understand?
Sorry, we lost you.
The teachers, and recently they have a Zoom one as well, just when they're going back to school, just to tell them about the development, whatever is going on. So, but they do with the teachers, I don't know for other students. But what they do is have that every now and again, the community nurse to come into the school and have a teaching with the staff so that they'll be aware of what is going on with that child. But if they've got a child in the school with sickle cell, they normally do it. But if they don't have any child in that school, they don't do it. I don't know if that helps.
No, that's really helpful.
At least they are in that school, or the community nurses are doing something. So yeah, that's helpful.
Yeah,
that's helpful, and it helps because I'm reflecting now in my school. Even when I was growing up in secondary school in Bodry Home, we had a friend who is now a professor, but she's sickle cell disease. But we never knew in school. We used to just say, "Oh, if they get bone pain, oh." We didn't have education at that time. It's only after we've all gone apart and I've come to England and met her. And then she told me that she is full-blown sickle cell disease, but she's been able, she has this, I can't call it weird blood. She has some type of, her sickle cell, she's able to control it herself. She's never on medications like other sickle cell children here, as I see in main teaching hospitals in London. And she's gone up, to be a professor. She's got a PhD. And when she knows her stress levels and everything. But we never knew in school, you see. So I think, school education by primary healthcare nurses or community nurses is key. Is key here. Thank you very much for that.
Thank you. Yeah, carry on, Dr. Achmed.
So look, let's talk about bone marrow and stem cell transplant, okay? Now, this is the only cure at the moment for sickle cell. What is it? So your bone marrow, it's the marrow in your bone, has all the cells that everything, all the sort of what we call progenitor cells, stem cells. So stem cells can differentiate into potentially any types of cells. So it makes our red blood cells, our white blood cells, our other cells in the blood like your platelets, etc. Now, if the problem is with the red blood cells, the idea is if they can get rid of your bone marrow, okay? So it's not an easy undertaking. So I mentioned to one of the parents earlier that, look, if your son, I think her son was doing really well with their sickle cell, not needing medication, etc. But she would still want them to have bone marrow transplant. And really, if your son is doing that well, they probably have a milder version of sickle cell. So you have the SS, you have SC, SE. They have a milder version and therefore will not even qualify for having a bone marrow transplant because it is highly risky. what they do in bone marrow transplant is they strip you of your bone marrow. So if I take all your bone marrow away, it means you don't have any red cells, you don't have any white blood cells. Your white blood cells help you fight infection. You know, all I need to do is stand like, I mean, this is an over-exaggeration because I'm actually I'm actually doing this with a screen in front of me, but I just need to blow or sneeze at you, and you're most likely to then pick up an infection from one of the bugs that you catch, and you can get it really, really bad. So, you know, you might get a cold and it's a sniffle and you clear it, but someone with depleted bone marrow will get a severe infection, life-threatening infection, might not even survive that infection. So they strip you of your bone marrow, and then they get you clean bone marrow from some other healthy individual, okay? But it doesn't just have to be another healthy individual. It has to be a healthy individual who also really matches you. They call it HLA matching, human leukocytes antigen. They have to match you up with that person, incredibly match you so tight, more than with any other type of transplant. You know, well, this is a type of, it's a transplant. It's like getting kidney transplant, liver, heart transplant, etc. But the match here has to be so tight, so perfect, you know, near perfection, for it to work. Okay. Now look, it's going to open up the discussion in another direction. Now, if that has to be the case, and so number one, you are, as a Black person, if you know, it's a disease that's more common in Black people, you're more genetically linked to other Black people. So the first thing is, you need to have a Black person who's donated their bone marrow, okay, or who's willing to donate their bone marrow to you, their stem cell to you. Now, I mean, how many Black people donate this thing? So you have things like the African ACLT, African Caribbean Leukemia Trust, and other organizations that are really encouraging ethnic minorities, Black people in particular, to be transplant donors for bone marrow and bone marrow stem cell. But anyway, that's an aside. So they strip you and they give you powerful medicine, and you're literally at risk of picking up any infection. At that stage, you can die. It's, you know, I'm not over exaggerating here. You can die from the slightest infection, and it takes a long process as well. And then they've got to introduce this new bone marrow to you. And what can happen is, when they strip you of your bone marrow, you have no, almost, you know, you can say you have no immune system, okay? You have no immune system. When this other person's new bone marrow comes into you, they can actually then start attacking your body, because you're getting someone else's immune system coming into you. And in order for them not to, that immune system not to attack your body, that's why, one, it's going to be perfectly matched, but also they're going to give you powerful medication to suppress those cells from attacking you, right? So it's not a light undertaking. In sickle cell at the moment, the only patients, there are a lot of studies being done, the only patients who are eligible for bone marrow transplants in the UK and anywhere, I looked at the guidelines, and I'm going to just go through that because I don't want to get this wrong for you. The only patients who are eligible are patients with severe recurrent chest crisis. So that's, I told you, that's one of the most serious complications you can get with sickle cell, who are not responding to blood transfusion, they're not responding to hydroxyurea, they're getting severe, you know, life-threatening complications. And they also, at the moment, you have to be under the age of 16 years old. And that's where all the studies have been done. The chances of doing well is greater if you're a younger person with sickle cell. And then the third thing is, there has to be a near perfect HLA match. If you don't fit that criteria at the moment in the UK, you're not eligible for bone marrow transplants, for sickle cell and stem cell bone marrow transplant. There's research going on looking at people between the ages of 17 and 35 years old. So those research are going on at the moment to see what can be done for those individuals. If you've had bone marrow transplant before the age of 16, and let's say you're now over the age of 16 and you develop a relapse, your bone marrow is not working, they may also consider you for bone marrow transplant. Now, finally, you have to be on powerful medications pretty much for the rest of your life to suppress the immune system. So it's a very fine balance. That's not even controlled by GPs, it's by hematologists. That's all they do. Look at hematological conditions. And there's this really rare complication, but terrible, devastating complication called graft versus host disease. And this is where the new bone marrow that you've developed sees your organs as foreign, right? And they will, for as long as they're within you, they will continue to see your organs as foreign and will keep attacking you. You will get problems. If that happens, you could potentially have lifelong problems with the organ they're attacking, whether that's your liver, your kidney, your heart, or whichever other organ. So it's there, and there's still really lots of research in it. It's the only cure for it at the moment, but it's very, very high risk. And as a result, it's not something that's available to every single patient with sickle cell.
Achmed, I think Tigdanke has got a question that she wants to ask.
Yeah.
Tigdanke, can you unmute,
Hello,
please?
Tigdanke.
Tigdanke, can you unmute, please?
Does she really have a question, or?
Yeah. Why? Okay. Wait, carry on, Dr. Achmed. Move on.
Is she there? Let's move on. Yeah.
Yes.
Okay, we're almost there. We're almost there. So look, that's bone marrow transplant. Now, what else is new in the field of sickle cell? There is gene therapy. I mentioned earlier, as adults, we always have the 2 alpha, but then we have the beta hemoglobin. But that beta hemoglobin only comes into action from about 6 months. So when a child who has sickle cell in their first, couple of months of life are unlikely to suffer any of the complications that we've just been talking of the last couple of hours, because they have the fetal hemoglobin, okay, the gamma hemoglobin. And that's really good at carrying oxygen and taking oxygen away from, taking oxygen to the tissues. So what geneticists are doing, they're finding ways of switching on your fetal hemoglobin so that it starts working again. So it goes to sleep, if we can say that, at the age of about 6 months. But they're finding ways to switch on your fetal hemoglobin. And I just want to play, it's a really short 2 minutes video that probably does it better justice than me. So I'm just going to play that here, and it explains exactly what it is. DJ Ish, let me know if you can hear this on your side as I play.
Genome editing technologies.
Yes.
Can you hear that?
Yes.
Sickle cell disease. One way is to turn on the gene for fetal hemoglobin.
Reverse sickle cell disease. Several months after birth, a molecular switch inside our bodies shuts off the gene for fetal hemoglobin and turns on the adult hemoglobin gene. In sickle cell disease, only the adult hemoglobin is mutated and makes hemoglobin S. To turn fetal hemoglobin back on, doctors first need to collect some of the special stem cells from your blood or bone marrow. These stem cells make new red blood cells. The cell's DNA can then be edited in a lab. Scientists usually use a vector to get all the genome editing ingredients inside the cells. Vectors are molecular packaging that are made in the lab. Often vectors are made from viruses, since viruses are great at getting DNA inside of our cells. To make the vector, scientists modify the virus to remove its harmful genes that cause disease and to add all the genome editing ingredients. One ingredient is a scissors-like protein. Another is a guide molecule that brings the scissors to the spot on your DNA that needs to be changed. The scissors cut the DNA, leaving a gap. The cell rebuilds the gap using a third ingredient of the therapy, a blueprint for building healthy DNA. In this example, the guide molecule seeks out the molecular switch gene that shuts fetal hemoglobin off. The scissors cut the DNA near the gene. The repair process disables the gene. Without the molecular switch, the cells make more fetal hemoglobin and less adult hemoglobin. These edited stem cells are returned to the body through an IV. The edited cells make healthy red blood cells. Learn more about NHLBI's research and clinical trials that support genetic therapies for sickle cell disease.
Yeah, so that's it. I thought it's a really nice short video on gene therapy. That's, I mean, if they can, you know, make this work, it will revolutionize things for people with sickle cell. I think it's fantastic. So look, so that's, you know, a lot on sickle cell. You know, I can't believe we're actually at almost 2 hours. Since we've been going. But there is one important thing I want us to get in here before we wrap up. And that is, look, you know, living a healthy lifestyle, including exercise. It's super key for sickle cell. And I know we have, you know, experts on exercise here. You know, DJ Little, with, you know, the fantastic, amazing work that you're doing with the countdown running. And you know, I just want to actually go public and congratulate you, DJ, on completing the London Marathon.
Thank you.
You know, just over a week ago, in a time of less than 3 hours and 20 minutes. I think 3 hours and 17 minutes. You know, what a fantastic job. As I said to you, this is like the minute mile that the great Roger Bannister, if you don't know him, he was the first man in the 1950s to run a mile on the 4 minutes, the 4 minute mile. And all of a sudden, the week after, lots of people were breaking the 4 minute barrier. So for us that know you in our community, if we ever thought, God, I don't think I can ever run a marathon, listen, just knowing someone who's done it has showed us that it is possible. You know, we can start by walking a mile and then running a 5K and then jogging a 10K. And maybe one day, you know, run a marathon. I'd love to run a marathon with you one day. And congrats to both of you for the half marathon. But you see, look, exercise. I don't know if you want to say anything, first of all, on that, you know, Mr. DJ Ish.
I'm just,
you know,
I've got nothing to say, Dr. Achmed. We just want to thank everyone for the support during the award that was given to us by AFWAT, and I want to personally thank everybody that supported me during the London Marathon, and with all your support, actually don't go in vain. That's why I was successful. Thank you, thank you, thank you, thank you. Over to you, Dr. Achmed.
Yes, no, fantastic. So look, exercise is important for lots of things. I think every show that we talk about, you know, why it's important to have a healthy, balanced diet, why it's important to have regular exercise. The thing with exercise in the context of sickle cell, it's just as important, but you've got to be very careful, okay? You don't want to overdo it, get dehydrated. You don't want to, you know, make yourself go into a crisis. And that's what some patients with sickle cell find. You know, they go to the gym because you find that, you know, you're strong, you know, just as strong as anyone. You can lift up the weights, you can run as fast in that moment. But unfortunately, if you overdo it, you get dehydrated and your cells start to clump up a bit more. You start to get the pain and the crisis. It puts you off from going to the gym again, and it, you know, you just don't go, and then you put on weight, you become unhealthy. You not just now are dealing with the sickle cell, you're at risk of then having all the other complications that come with, you know, lack of exercise. Let's put it that way. So it's, again, if you speak to your hematologist, you speak to your GP, go on the Sickle Cell Society website. We all really encourage you to exercise, but don't be overzealous with it. Be gentle with it. Make sure you carry water with you. Hydrate yourself before going, hydrate yourself during the process, and you should be fine. I don't know personally anyone with sickle cell who's run a marathon, but I'm sure there are people out there who run a marathon at their own pace. But certainly I would advise, don't go into it blindly. Speak to your clinician, especially your hematologist, if you're going to take on such a huge venture. So that's all I have to say about healthy living and exercise. That's all I think I have to say about sickle cell disease today. If there are any questions, anything else in the comments, I'll be delighted to address them before we close the show.
Well, we've got a comment from Auntie Elizabeth. She said, thank you, thank you, thank you, thank you. And I will actually encourage DJ Little to say something before I come to the panelists who have been with us throughout this 2 hours, just to give one or two, if they want to ask you anything before you go. DJ Little. Okay, if DJ Little is not there, I'll come to the panelists first. Natsby, I don't know whether you're still with us. Have you got anything that you want to say to Dr. Achmed before we wrap up, please?
Just really very informative. Keep up the good work, and I would like to see more topics relevant to Black health or BEM health on shows like this.
Thank you.
In
thank
conjunction with what we do in Toshba.
Thank you very much. Thank you. Thank you. Definitely, Dr. Achmed will look into that. Thank you very much. Thank you for being with us tonight.
Thank you.
Auntie Elizabeth, over to you.
Yeah, okay. Right. Yeah, I think for today, really being Black History Month in October, so the talk on sickle cell is in place. Doc, thanks very much for refreshing our memories. Right, and especially the one about malaria and sickle cell trait, etc., and the bone marrow transplant, because people need to be educated about all those things, the risk, how vulnerable you will be when you do those things, and then who is eligible. Thank you very much. Keep up the good work, Doc. All right.
Thank you, Auntie Elizabeth. Thank you. Sister Danke, I don't know whether you're still with us. If you are, have you got anything to say to Dr. Achmed before we wrap up?
Yeah, thank you very much. We appreciate you for doing for we in the community, because we have great opportunity today. At least we benefit. And the other thing again, I just want to say about the lady who said, oh, about medication or stopping treatment. I don't stop the treatment for my son. My son is still taking all his medication. I am giving a testimony about what God did for my son. I'm not trying to frustrate or provoke any other family. For my own side, I am blessed. It's a testimony that my son don't have crisis for the past 8 years. He has only have blood transfusion, which is one time. So I'm giving my own testimony and what I'm doing in the house, which is benefit again, I want to say. My son eats most African food. If he cook plazas, we not get pamai, they tell you say the plazas now move plazas. They eat cassava leaf, they eat potato leaf, now yeah, bona. They eat, I know they eat English food. So all that one is a support, and thank God for God and Jesus. Me picking well. They take all the medication, everything they take them. They do well. So I thank God for that. And the doctor, may God bless you for make we hear today what you say. Thank you very much. We love you.
Thank you, Sister Danke. Thank you very much. It's honestly, it's been busy.
I think Auntie Elizabeth has her hand up. Auntie Betty has her hand up.
Yeah, just finally, we Sister Danke, we just don't say, about his son. I'm so glad I think you don't so study the disease or the condition from the time where they go down, tell you from the beginning, and then you serve the support you became, because as a nurse in teaching hospitals, I can see, I don't know a lot of sickle cell patients from St. George's, King's College, St. Thomas's, etc., and Lewisham Hospital. Some of the parents know they help, you know, they're not a help for make sure the pikin then take their medication. Of course, you can't stop it. Some people, like this, my friend, where I describe in triggers. So anything where they trigger,
You avoid it.
they avoid them. Like in a lecturer, I can get boku paper for mark. Like that in college, university for say, me own time in when I go for prolongant. So it's saying can space himself. Yeah, in order to exhaust himself, because even just sitting down marking papers under stressful condition, you get boku paper for mark, it's a trigger for her. Think that they way, if you were can come out to go on canal, we go on, they go say, no, me, I know they go under me, and you know, no, say me, and you know, say me different. You know, it's knowing yourself. I'm glad the way they eat everything, you know, your body eats everything. Where they nourish itself, because all that is part of the nutrition. You know, thank you very much. You know, maybe you go for be one of them parents where they go educate the other one then.
Parent
Whatever,
champions.
you know, patient experience. Yes, you go both even give a talk somewhere. How in the manage itself where you don't go for 8 years will start crisis. Yeah, small. Thank you very much. Yeah.
Thank you, Auntie Elizabeth. Thank you very much. DJ Little, have you got anything to say before Dr. Achmed close the show? DJ Little. All right, okay. Dr. Achmed, yeah, you can wrap up, and I don't know, you've got one or two things to say to the audience and for everyone that has been with us tonight. Over to you, Dr. Achmed.
Yeah, look, thank you all so much. I think this is a testament to the power of what we can do within our community. We're educating ourselves, but also we're educating others outside. Thank you to all the contributors, everyone who's actually come on board on the Zoom tonight to participate. Thank you to everyone who's been so active on the Facebook with your comments and questions. It makes the show more useful because we can talk for forever and ever as clinicians. But what's useful is how we respond to the queries and questions that you have. Much appreciation to DJ Little and the Diaspora Voices platform. All we want to do is put you in a position where you can really be educated about your health. You can be a master of your own health, take control of your own health, have a high-level conversation with others. You know, we've just this weekend had a boxing match, and there's a famous saying by Mike Tyson that everyone has a plan until they get punched in the face. And if I use that in the context of health, we all think we have perfect health until ill health meets us, and then we start scrambling. So look, we can't stop ourselves from getting unwell, but if we educate ourselves, keep ourselves in the best health as possible, when that illness comes, we probably will have a better chance of doing well and succeeding. So thank you so much, and we look forward to seeing you again next month for another exciting show.
Right, Dr. Achmed, before you go, apart from this talk show, can you just tell, because this is the first time we've seen this kind of audience, can you just tell them what you do as well? Because behind you, you've got a screen behind you, Doctor to You. So a lot of people may not know what you do as well on the side. So can you just explain to the audience, please?
I love the way you say that, on the side, because yes, this is Diaspora Voices is my main show. Everything else is just on the side. Well, look, yes, thank you so much. I mean, I'm a UK GP. You know, I work in Southeast London, mainly between Southwark and Bromley now, on the NHS. You know, before that worked as a respiratory registrar in hospital. I love research. I was an academician before coming on to becoming a GP. And I love serving my community. You know, that's why I do shows like this. You know, I've exchanged lots of knowledge with Auntie Betty on the show tonight. You know, you've helped me a lot. Everyone in your organization, Toshba, you guys do a great job as well. I think we all can't do it all, but we just support each other. and hopefully collectively we can cover all the areas that we need to cover. What you can see behind me is Dr. Tui is a private online and consultation service. I see patients purely online on video like this. You know, we've learned with the pandemic. I mean, I was even doing it before the pandemic. I was doing a lot of video consultation with another company. And that's what triggered me to start this company. So it's not just a pandemic issue. I was doing it well before. But we've also, you know, incredibly learned that we can solve, you know, with the right questioning, we can actually tackle a lot of medical issues and help patients online. And that's what I do privately. You know, we can, there's loads of conditions we can help with. And nothing emergency, of course. And if someone needs to be seen physically, at the end, we'll tell you and we'll give you some advice on how to do that. We do prescriptions, we do medications, not control medications, but lots and lots of things. You can find us on www.DR2YOUTopic.co.uk if you want to have a private discussion with us, or follow us on Facebook. You don't have to, it's not always about paying, you know, this is free, this is a free service. That's why, you know, you hardly hear me talk about Dr. Tuyu and what we do, because this is really just to give you useful knowledge. I think they say, in fact, that there's so much unused knowledge at the cemetery, because lots of people have things and they die with it, they don't share, right? We all have so many good things. Let's just share what we have, you know, even if it only helps one person, it's made a difference to one person's life. So it's absolutely worth it. Thank you very much, everyone.
Thank you, Dr. Achmed. DJ Little, over to you now.
Yes, hello, can you hear me?
Loud and clear.
Dr. Achmed, DJ Ish, and all the contributors to tonight's program. It's been a fantastic program, and really the engagement has been full on, and we did anticipate that the program was going to be really rich in terms of contribution, but obviously we did not anticipate it was going to be this full on engagement. Well, it's interesting to see that the parents have valued this program tonight, Dr. Achmed. And what I wanted to find out in terms of, and I know you're wrapping up, because what I wanted to find out just quickly in terms of, sorry, apologies. What I wanted to find out just quickly in terms of young people who have now got themselves into that situation, because we talked about where people will meet each other. Somebody mentioned to do with universities and all of that stuff. And if they've happened to start a family, or they meet each other and then they start a family, there's not much that can be done now except for just managing it. And now we've seen younger people on social media, how they can share their stories. What advice can you give to ensure the opportunity to have a prolonged family life, just briefly? And I know we're wrapping up, but I just want you to just touch base on that. And I know we've gone beyond time before we wrap up, please.
No apologies at all. I mean, I think, you see, genetic counseling is very important. Knowing, again, it comes down to education. And look, it also, we have a responsibility as parents, because we know we should be in the position of knowing before the child, who then becomes the teenager and the child going to university, finds out that they have sickle cell or sickle cell traits. So if we know that we have sickle cell traits and your parents, you know, we should be informing our children of that, so that when they get to a certain age where they're going to be involved in relationship with other members of the opposite sex, that they also find out what their status is in terms of sickle cell. There's a simple blood test you can ask your GP for. It's not your blood group. Lots of people come and see us and say, "Oh, I want to know my blood group," and then say, "No, why do you want to know your blood group?" And then eventually, you know, the conversation, well, you know, I want to check if I have sickle cell or sickle cell. It's not your blood group you need to know. You need to be really direct with the clinician and say, "I want to check whether or not I have sickle cell," and there's a particular blood test, hemoglobin electrophoresis, that you can have done. So it's that education, and if you know what your status is, whether you have traits or not, And then, you know, you ask your partner, do you have traits or not? I mean, you can't choose who you fall in love with. It's about understanding. So we talked about what the chances are that your children, your offspring, will have sickle cell. It's knowing the risk. It's not saying don't have kids. Nobody can tell you not to have kids. Every single child is equally valuable, whether you've got sickle cell traits or not. But it's knowing, being responsible enough as a parent to know, well, what are the chances? So that if you have a child with sickle cell or sickle cell, you can give them the best support, that is available, so that they can have the best life possible as they grow up. Yeah.
All right, thank you very much, Dr. Achmed. I really appreciate, and apologies again, sorry. DJ Ish, fantastic program. And I want to say to all my the wonderful guests that joined the program on the Zoom, thank you so much for your engagement, and to all the callers as well that called through the program. Thank you so much for your engagement as well. And it's been a brilliant program. Let's continue to raise awareness and continue to sensitize our community and support each other. Thank you once again, Dr. Achmed, and over to you, DJ Ish.
All right, thank you to all our listeners, our viewers, our callers, and for all those who actually stay with us up to this time. Thank you very much. We hope to see you guys again. Definitely, you will see Dr. Achmed again very soon in the next 2 to 3 weeks with another interesting topic. But if you want to reach out to Dr. Achmed, please feel free. You can reach out to us, or it's easy to find him. If you have any question, any query, you're more than welcome. He's always there to actually assist the community and assist you. We want to say thank you to everybody. And thank you, Dr. Achmed, for giving up your time to educate us tonight. Thank you very much. And good night, people.
Just before we leave, just want to say we're back tomorrow because now we've got a Tuesday's program from Zainab Zorokong. And she's talking, following on the Black History Month series, as we know, October is Black History Month. So Zainab is going to be talking to Blee J. Innes, is a young British American, British and American African, how should I say, African British American, that's the word. And he's going to be talking about Africa under construction, and basically is into real estate, and he's trying to encourage most of us as Afro-Caribbeans not to be hesitant to get involved in real estate. So we need to get involved in real estate as Afro-Caribbeans, young people, and he's going to be giving advice on the ways and the means of how we can do so. So please join the program tomorrow from 8 p.m. And the program is In Conversation With, and is hosted by Zainab Zorokong, and our guest is going to be Blee J. Innes. Thank you.
Thank you very much. Thank you.
I'll be watching that one for sure.
Thank you. Thank you, people, and good night. Thank you.
Thank you very much. Stay blessed, people. Thank you all for your contributions, and we'll speak soon. Okay, guys, we're offline now. Let's talk. Well done, Dr. Achmed. Sorry.
We produce 100% natural organic drink.
No, thank you so much, man. Fantastic. Well done.
Dr. Achmed, the engagement today